Hello, my name is Magdalena and I'm one of the nephrology fellows here at Sick Kids. I want to present to you a poster on utilizing pharmacokinetic studies to optimize therapy in a child with nephrosis and C3 glomerulonephritis, a precision medicine approach. The case I want to present is a 6-year-old boy that presented around 1.5 years ago with nephrotic syndrome, severe hypertension requiring 4 antihypertensive medications and acute kidney injury. His C3 was low and his kidney biopsy showed C3 glomerulonephritis, as you can see in figure 1. He was started on prednisone and MMF for 5 months and had no response. He was then commenced on eculizumab with standard atypical HUS dosing. So after induction, he received eculizumab every 2 weeks. Again, as you can see here in figure 2, there was no response. He had persistent hypertension, persistent nephrotic syndrome requiring weekly albumin infusions, and increasing creatinine. We did have evidence for suboptimal terminal complement inhibition with persistently low C3, elevated C5p9, and low plasma non-C5 bound eculizumab levels, and we also were able to detect eculizumab in urine, indicating urinary loss. As you can see here in the figure in the middle, on top the treatment that he received, and below that you can see protein, albumin, creatinine, C3, C5p9 levels, and MPA AUC. In terms of his pharmacokinetic studies that we've performed, so we did MPA AUC monitoring that showed persistently low AUCs, and we had to further up-titrate his dose, and is currently receiving 700 milligram Q8 hours to achieve an MPA AUC of 35. We did rule out that he's a fast metabolizer. We did some eculizumab monitoring by sending eculizumab levels, which is free non-C5 bound eculizumab, several times, which indicated that he has very low levels at 2 weeks after his last dose. So therefore he was switched to weekly infusions from month 11 onwards. And for that we saw rapid clinical improvement with improved kidney function, improved proteinuria. We were able to discontinue his albumin infusions. We were able to discontinue all of his antihypertensive medications. He does continue to have persistently low C3 and proteinuria, and we continue to work to optimize his MMF AUC. The discussion I would like to have is about the use of pharmacokinetic studies that I think can really aid in individualized therapy, especially in patients with nephrotic syndrome where they have the possibility to lose MMF or eculizumab in the urine. Please let me know if there's any further questions. Thank you.